There it goes. Got it. Since this is my committee and I can do anything I want, you guys don't have to sit out there. We're one happy family. And if you want to sit up here, that's great. David, you're the smartest guy in the room about this bill. Feel free to come up here if you want. I just find it easier than staring at a dark cloud space back there. Anyways, this is the interim study subcommittee for House Bill 554. Prime sponsor is David Lundgren, who is here today, which is great. I wanted to begin by just reminding people what the purpose of this bill is and why we're here and why this is important. As many of us know, there was a, quote, opioid crisis that happened. I personally believe that it was disingenuous that all the blame for the opioid crisis was placed on pharmaceutical companies because there was plenty of blame to go around. One of the faults of the healthcare system was a failure to provide access to multiple therapies or alternative therapies, preferably in an integrative manner. This bill has come up several times, twice through Representative Lundgren, and it's an attempt to try to increase access to therapies that we know have value. And the next question is, how can we do such in a cost-effective manner that doesn't unnecessarily burden one group over another, but in the end helps the people that we're trying to serve? So that's why we're here today. This is our second meeting. I handed out an agenda for everybody, and the first order of business is for those of us that were here before was the minutes from last time. Are there any questions about that, comments, thoughts, whatever?
I don't remember what that word was either.
What's that? Yeah, I know. It was your comment?
It was my comment,
Yeah.
but I think it sort of says enough without another word added.
So for the record in the minutes, you're looking at the guy that kept them, and I didn't write it up till about a month later, and Bill made probably the most astute comment, Representative Palmer, sorry, made the most astute comment that will ever be made at a legislative session. I couldn't read my own handwriting, so it never got documented. So I just wanted to give a brief overview of where we were, where we're going. But I think the one thing that came out of this was that we pretty much were in agreement that we need to move forward. One of the issues that was brought up, that was actually brought up in our integrative pain committee also, was what's actually the definition of pain, which is why that's the second order of the meeting today. The third issue that we raised was that whatever we do needs to be evidence-based, but also that the evidence base that we use is consistent with that used for other modalities. For example, we can't give certain allopathic treatments a free ride merely because they're allopathic. The level of evidence should be similar. We should be fair to insurers. It's a tough world right now, and we should be fair to them. We need to be fair to consumers, and we need to be fair to the healthcare system. And so that's where we are today. So as the next, are there any questions about that? Thoughts, comments, whatever?
Mr. Chairman,
Yes.
it's been a while since I read the bill. Are those currently addressed in the bill, or are those things that would need to be added to a new bill?
So the bill that you have in your hand is my proposal for
This is the current bill.
the amended version. Yeah, yes, everything that's there is in that bill.
Everything you
haven't
just
removed
mentioned
anything.
is in here?
Yes.
Okay, great, thanks.
Yes, everything's in there. With one subtle difference, and that's what we're about to talk about right now. So what I did was, so the third item on the agenda is to talk about the definition of pain. And I'm not going to burden this group with this, but when we did our integrative pain care committee meeting, that was the first item that was brought up, is defining pain, which then went on for a 2-day discussion. And I don't think all of us want to be here, but in the end, the version that you have right in front of you is what we came up with. The International Association for the Study of Pain redefined this in 2020. What's in red on that handout is additions that we made to their definition. Do you have that? I can give you that one. I'm sorry, I put them back there. I should have given you one.
Mr. Chairman, is this the language that appears on page 4?
No.
No.
In the bill itself, you mean?
Well, I'm looking.
No, it's, I
Okay.
can get you a copy. They're right over there, yeah. Yep. So this is
Oh, I
the
thought
subtle
the one with
difference
the-
is what's there is not what's in the bill. What's in the bill is the historic, International Association for, actually, I think you,
So I just want to be sure I'm looking at the right piece of
yeah,
paper.
no, it's not
Um,
that. And in fact, you
Because
brought
this
up,
has a lot that's been struck out, but it's
Yeah.
got stuff that's left in,
This is
so.
one page.
Okay.
exactly. it's
So
a
this is going to
one-pager.
supersede what's in here.
Maybe, that's the point of discussion. Should
Thank
it
you.
or
I
should
just
it
want-
not? Yeah. I'll give you a couple minutes to go over that.
Is this the one that you brought back on the floor? We had a special motion or something?
No. No, yes, actually, you're right, it does, yes. It was for that bill. Well, you got a good memory.
Sometimes. I just turned 70. Not as agile as I used to be.
I'm trying to catch up.
Lucy hasn't hit 30 yet. We're talking about age. You haven't hit 30 yet.
Are we on video or no? Is this on video? This meeting?
Yeah, it should be live streamed,
All right, fine.
which means take your microphone off again.
I'm not supposed to advertise.
So just as a drafting question, because I'm now working off of this, which is, I think, what's under consideration. Are you considering putting the clarifying parts into the bill, or is that what's under discussion at this point?
That's under discussion. I think it's kind of, just as a background, are we ready to talk about it? So historically, if you look at the first paragraph, the definition of chronic pain up till the end of the eliminate the red items in that first paragraph. That's the historic definition we've always used. It's pretty much what's in the bill. It became apparent by 2020 that it, for reasons that we actually brought up at our committee, our integrative pain care committee meeting, that it wasn't sufficient. And so they commissioned another study group to look at that and redefine it. And so that's where the rest of that came from. I mean, I think if you add patient-centered in 3 months to the definition, you've probably done enough for the legislative element of it. But I'd be happy to see what other people think, because the rest of this, in my world, is like really important. And what we're doing in the Integrative Pain Care Committee, it's really important. I don't know if it's as important for this bill.
Question, I haven't encountered the word nociception before.
So, in a nutshell, pain exists. There's two elements to pain. There's nociception and suffering. Nociception is the actual neural process by which a nerve ending is stimulated and gives your brain a sensation that something hurts and you develop a reactive response. Suffering is the element that, that's more the emotional and diffuse response to the painful stimulation. And so in the chronic pain world, they're both important. And at some point, actually, the suffering is more important than the nociception, but they're both important. Does that answer your question?
Yes, absolutely.
Okay.
I would think that, as you go forward with this bill, the definition of pain should be more or as succinct as possible. I think the meat of this bill has more to do with the insurers, the providers, the medical system in general, and I would argue that, you know, the definitions that you put down there in the bullet points may not be necessary, except to understand it better for ourselves. And one of my other questions is, I don't have a problem with patient-centered. I do wonder about why it was necessary to change the current definition and why the addition of the lasting more than 3 months is in there as well.
For our purposes, we needed to define, for the Integrative Pain Care Committee, we needed to define what group of people we were going to target. So we were going to target people, like that level of care was probably excessive for somebody who had pain for less than 3 months. So we kind of arbitrarily came up with a 3-month definition. For what we're doing here today, it's not important.
Okay.
So, I mean, the patient-centered, actually, interestingly, I think, and if you look at the minutes, you're the one who raised the patient-centered thing.
Right.
And to me, it's absolutely critical because we're providing healthcare based on algorithms that are lumping everybody into one giant category. And we're trying really hard in healthcare to not do that.
Mm-hmm.
But in the business model, that's the way it's done.
Thank you.
So yeah, I mean, the patient-centered sort of can incorporate a lot of these bullet points, so that's nice. The only thing about the 3 months is, so if we're talking about insurance coverage, then that's kind of important whether we put it in or not, because, you know, if it's only 2 months, then maybe it's not covered if we put in 3 months. So I guess that's the question: is should there be a time limit in the bill at all? Or is that's my question.
It's a good question, and the reason I would say we don't need to put it in is because this bill is addressing both acute and chronic pain, so the time frame really doesn't matter. Yeah. So, okay. Yeah. I have a left-sided field neglect here. I should probably be over in that corner or something. We'll wait for him.
So just to recap, I mean, what I was about to suggest is that you have two definitions, one being pain and one being chronic pain, which has the durational aspect. But if people are satisfied that all we're defining for respect of this legislation, you can just go with the definition of pain and not have to decide what the limitations are. But it's easy just to make the two different definitions.
You know, it's interesting, just pat our sponsor on the back. If you look at outcome data, the most efficient way of dealing with acute low back pain is actually with chiropractic care. And that was the whole purpose of this bill, was to try to increase access to that. As an acupuncturist, I know my treatments work much better on acute pain than chronic pain. And virtually all of us healthcare providers in the room can say that. That's true. And so that's why the time element, I don't think, needs to be defined here. But if we feel strongly that it should be, that's fine. Representative Merton.
Thank you, Mr. Chair. During the discussion, I think one of the reasons for the 3 months was trying to find a demarcation to separate chronic from acute. And again, back to the insurance, having something in there as a timeline to help the insurance folks and everybody else and providers, that Representative Murphy brought up as well, is where is that line from between acute and chronic? It's not specific, but we had to draw something somewhere. The other side of the coin, too, when you talk about patient-centered, when you start talking about pain, what I began to understand, a lot of pain is subject to the person's own interpretation of the pain. So what may work for one patient may not work for another one. And when you get into the issue of who should decide what works and what doesn't work, it really should come down to the patient. Because it may be things that the studies say it doesn't work. And a lot of times pain can be controlled by a placebo. It's the mental part of it. And that's what Representative McKay was talking about as well. We can't forget about the human brain. And that part of it has to be there too, which is sometimes the emotional side of it. So that's why those two things were woven in there. One was to give some sort of differentiation between chronic and acute, and also be sure that we're centered on the patient and what they're providing to the provider and saying what works and what doesn't work, versus somebody saying, well, there's no article out there, there's no science behind it. Well, a lot of times when you're treating pain, it doesn't always come down to the science, it comes down to the patient.
But I don't think you can, I mean, it's certainly true that amongst different modalities, one might work better for a given patient, but I don't think we can ask for an insurance company to cover something for which there is no evidence. Because the fact, if one patient says, you know, ground rhino horns just makes my back pain so much better, I don't think we want to, you know, have insurance companies feel that, I mean, if you see what I mean.
Yeah, I totally agree with what you're saying, Representative Palmer. The challenge, though, is that when you get into the science and trying to get into something that's evidence-based, we put sometimes so much emphasis on the evidence that sometimes it seems, you do drug trials, for example, we know that the drug may work in a certain population, but it doesn't work in all the population. So therefore, when you look at it and saying, well, the study says it works, but the patient will tell you it doesn't work because it doesn't work in that subpopulation. So even though we have trials and we have evidence-based, it should not be construed that we have to rely upon it completely. So that's what I'm trying to be sure of, is that even though the science is there, we have some way for the patient's involvement and feedback from the patient as well.
So it sounds to me like one of the things you might want to think about is viewing the evidence base as a floor rather than a ceiling, because we do know, I mean, I'm just thinking about the usual painkillers that people buy in the drugstores. Some of them work for some people and some of them work for other people, and some of them have side effects for some people and for other people they don't. So, and I'm not sure for purposes of the bill you need to define this completely, but I think some kind of floor of scientific evidence is important. But the thing that I learned through my late husband's cancer treatments was I always thought that, you know, you had condition A, you administered pill C, and you B and got result C. And of course, that's completely untrue. It's far more art. It's an art and a science. And that's why I like the patient-centered point, because that's what you're looking for, is what works for this patient, but with some guardrails on it. The rhino horn.
And this is where we
out.
get into the problem, is who gets to define what the evidence base actually is. And it's, when we did our prior authorization bill, one of the big problems that we found was that each insurer is using their own evidence base. And, you know, without any ability really for us as practitioners to question, well, what's your evidence base? Why are you using it? One of them, I'm going to cite my book again, sorry, but one of the more important chapters in that book was Myths and Realities about Evidence-Based Medicine. And there was a study of the Cochrane data collection, which is the largest collection of evidence-based medicine in the world. It's held in Scotland. And not that you need to know that. But anyways, what they did was they looked at 1,100 medical questions and defined how many do we have no facts, how many are satisfied beyond, question, whatever. They found out only 3% of medical questions among the 1,100 were settled beyond question, which means that 97% of medical questions, there's a question. And so that the reality is that there are no facts. And that's where we get back to patient-centered care. And that's, to me, to be honest, you have maybe inadvertently raised the most important part of this bill, to me personally.
Thank you, Chair. No, one of the other things that was discussed was, if it is patient-centered, instead of trying to micromanage it, is trying to find a way, if we could, is give the patient a bundle, if you will, of dollars that they could utilize, and let them at that point in time be more in charge of how those dollars get allocated on their care for chronic pain, and let them sort of have more stewardship over how those resources being utilized versus us at that point in time trying to say, well, this works, this is covered, because it becomes so difficult trying to figure out what to include and what not to include. An example, in hospice, they don't, in hospice, you get a certain amount of money per diem per day. But it's up to the hospice organization to decide how to utilize the dollars. And it's up to them to decide what works and what doesn't work and what they want to use the money for. So that kind of breaks it apart. So the insurance industry has some sort of obligation to the patient, but at the same time, there's also some freedom within the patient themselves to how those dollars get utilized between themselves and providers and so forth. So if they want to use it in Tai Chi because it works, there's a limited number of dollars that are available. That helps reduce the risk factor from the insurance company because from a financial risk, it at the same time gives the patient more control over those resources.
I mean, thank you. That's an interesting idea. The only thing, the difference is that in hospice, the hospice team, medical team, is working with the patient to decide. So it's not just a patient-driven thing. The patient doesn't have unlimited options of what the hospice agency is going to pay for. And so having been a hospice medical director for a number of years, I mean, we certainly had people, I mean, you know, like Father Gill taking the guy fishing was one of the ways we spent some of the hospice money. I think he was actually a volunteer, but that wasn't a medical treatment, but it was very good for the patient. But as far as medications or other treatments, it's still got to be ordered by a doctor. So presumably the doctor's not going to order the ground rhino horn. So there has to be some balance because otherwise, the only other way I would think you could do it would be to make a list of different things that would be covered, which then gets to be either very difficult to do in, you know, a huge negotiation or it's going to be limiting in slightly different ways than what we do now.
Thank you. I thought you were going to speak. I don't disagree with everything that has been said so far. And from a clinical perspective, your thoughts that the definition of chronic pain and particularly patient-centered approach to it is very important to us. I understand that. And I would not disagree with any of the bullet points, though I don't believe that they need to be included in the bill itself per se. My suggestion is that the definition of chronic pain could be as previously stated with the addition of patient-centered, because I think that the major part of the bill that is going to be controversial is going to be the burden that's put upon providers and upon insurance coverage. So my sense going forward would be that we look at the what we have written down as chronic pain and modified with patient-centered because it is patient-centered in many ways. But I agree with it as being very important. But I think that we really ought to be getting to some of the more controversial parts of the bill that are going to be what is mandated for providers and for insurance coverage to be included within the bill.
Would you keep the 3 months or remove it?
I would remove it.
Yeah, perfect.
Because I think simple is better. And the reason I would remove it is because I think that pain is a very subjective thing. As soon as we start getting into more of the details involved, the mandates of 3 months and the time periods involved, et cetera, the more difficult it's going to be as a provider, provide coverage for that pain.
And I'm glad you said what you said because we are getting into the discussion of mandates.
The
and
weeds.
That's a big deal.
Yeah.
And I mean, I'm fine with that. I'm perfect with that.
Would there be some consideration by the committee to include the word usually lasting more than 3 months? Which gives a little more flexibility. Again, the same thing, and just trying to look at it from the insurance point of view, but in some words.
Go ahead.
For the purposes of this bill, didn't I understand people to say that we don't need a definition of chronic pain, we just need a definition of pain?
Exactly, yes.
And therefore, we don't need to do the limits. And if there's something farther on in the bill that addresses a chronic condition, then we can look back at that. But speaking as the most lay of lay people here, anytime somebody says to me, lasting more than 3 months, that means that somebody's got to hurt for 90 days before something happens. And I don't want to get into a situation where we're arguing about that down the road. So unless there's a reason, in which case we should define pain and then define chronic pain, I'd just leave it as pain and go forward there and then deal with the meat of the bill, which is going to be the thing that's going to cause pain among our colleagues.
I would second that, and I would say that it was an omission on my, commission on my part. Chronic should not have been here. It should have just been definition of pain.
So are we, then, I missed that part, sorry about that. We're deleting the word chronic in the definition, so it's just definition of pain.
Exactly.
Okay, thank you.
Yes, Representative McDonald, sorry.
Thank you, Mr. Chairman. Yeah, getting back to Representative Murphy's comment about the insurers, I think that's our number one hurdle in this bill from everyone I've talked to in the House. I know at least one lobbyist is here from, I think, representing insurers. I think that's one of your clients, right? So that's the number one challenge I think this bill has, and it's an important bill, and I'd love to see it become law, but that is going to be a major consideration in talking about stakeholders, talking about people who need to be in the discussion and so forth. I think that's probably our biggest hurdle and our greatest priority in getting this bill passed.
So are we okay with the definition as Representative Murphy has proposed? And all of us, actually.
So just to be clear, your suggestion is that definition of pain, as you wrote it out there, would eliminate chronic pain, keep patient centered, and lasting more than 3 months is what you would include in that. Okay,
We okay with that?
I am.
We don't need to make motions and things like that, right?
Still working.
And that simply means that, to go back to the thing that looks like a bill, what we're going to do is insert the words patient-centered, and the rest of it stays exactly the same.
Perfect. Good job. Who says government can't accomplish things? So that brings us to the next thing where we actually look at this bill. So I just want to reiterate some of the background of this bill, where it came from. This bill, I think, has been proposed 3 or 4 times now. Representative Mangiapudi did it first, and then Representative Lundgren took up the flag. And then we had met well before I became a legislator. Because we thought that this bill was really important. So what we did was we took the bill, because we at the Medical Society had concerns about it. But I also work with the U.S. Pain Foundation, and the woman that I work with there, Cindy Steinberg, who's not here today, she's their legislative representative nationally, and she's also their chair in Massachusetts, and they had actually created a somewhat similar bill there. So what we did was we looked at the bill that they had created, and we brought her across state. We put together a work group that consisted of a couple docs, me, well, I'm a doc, Cindy, and the reason why Cindy was important, not only was in her legislative role, but she's also a patient with chronic pain. So, and she represents millions of people, not just a couple. So we sat down, we went through the bill, and what ended up coming up with was of taking a lot of what Representative Lundgren had created, changing it in a manner that the Medical Society could back, be a little bit more specific about what we were after, eliminate a couple things, like there was a report in there that probably isn't necessary. We could go over that in detail. And then we came up with a format that ended up getting submitted as House Bill 303 that then got attached to what was the original. 554 was, I don't remember the original bill number from a couple of years ago, but so now we functionally have 2 bills that are side by side. So what I tried to do in going through this with the red and what was struck out, what wasn't, what was added, was to try to morph them into something that's a lot shorter, simpler, and will hopefully accomplish what came through in a number of our meetings. Specifically, the original bill included a number of things like Qigong, Tai Chi, yoga that are not provided by licensed therapists. So the general consensus was that whatever we deal with in this bill now needs to be done by a licensed therapist. So the things in there are like movement therapies, chiropractic, osteopathic, something that might be done by a PT, but it's important to say this bill does not include physical therapy. Massage therapy, which is performed by licensed providers, acupuncture, which is provided by licensed providers, psychologic therapies like cognitive behavioral therapies and things like that, which are provided by licensed therapists. So we really got way more specific on it. And this was done as a group. It wasn't just a me thing, and what you're looking at is actually a group effort by people that represent pain, people represent doctors. The one missing piece is insurers, and what we've tried to do is include you guys in this too, so that we get something hopefully that'll be nice for everybody.
So I'm still looking at this document in front of me.
Yep.
And so is the proposal going forward limited to the wording in red? Because I've got wording in black, which sort of looks to me like it's staying in the bill. And if it is, then on page 5, we still have aquatic therapy, yoga, Qigong, and Tai Chi, which are the modalities that are less likely to be licensed professionals.
Thanks for bringing it. What line on page?
I'm on page 5 and I'm on line 10 and 11.
Yeah, that will need to be removed, yeah.
Okay, I just want
That
to be
was an
sure
omission.
we're all
No, thank you, because that's important.
looking at the same thing.
Yeah, anything in red that's struck was original, that's been taken out. Anything that's red now is either moved from
Right.
one place to another or is new, and anything in black is original that's staying.
Okay. got it.
Which document are we looking at?
Oh, it's
Right.
the thing that says
Okay,
bill
thank you.
number at the top, and it's 5,000 pages long.
So you're going to strike lines not all of line, because some of the movement therapies, physical therapists and chiropractors are certainly licensed professionals. And then I'm not sure about the ones going forward from there, but I just think you need to
Yeah.
make a note that somewhere there you're going to have to start drawing lines.
I don't know if I can say this out publicly, but you're a smarty pants. Thanks for bringing that up. And I mean,
Doesn't know if you can say it.
This
I
is
just- I'm
this
sorry.
is why I'm the token attorney on this committee.
no, and the reason why PTs are not included in this is that insurance and physical therapy are not an issue.
Right.
So that's why we didn't include them in this bill.
Well, then I think it's would, you might want to discuss where that sentence ends, or if it's included at all. I'm just putting a question mark by it.
If I could go back to a comment before about the rhino bones or whatever we're talking about before, if it's ordered by the provider, would that not be covered? No, I was trying to get to with Tai Chi and so forth, that the provider thinks it's going to work and help the patient. Would that not be again, the floor we're talking about where it's being somewhat controlled by a decision by a certified individual that has a license to interpret that? Representative Weber.
And I'll just say that traditionally, when we've looked at bills like this, and it has been an issue back and forth, and I think that, you know, what you're talking about is basically having a gatekeeper, and somebody with a license has to say, yes, I think this is going to be helpful for this patient, but you still have the issue, and I think it's going to be a very huge issue depending on who the payor is. If you are referring to somebody who is not subject to license or certification rules of some kind, you're going to run up against a huge roadblock. I'm pretty sure that the CMCs are not going to be happy with that, for one thing, and that's a huge amount of the coverage. And this may not cover that at all, but it has traditionally been an issue going forward.
Representative Palmer?
Well, what I was going to say is that, I mean, the rhino horn thing, that's basically like medication. And so there are going to be medications that you'd have to go through some prior authorization to get because of whatever reason, either because they're very expensive or because there's no, evidence. Obviously, there'd be a lot of different medications that would be helpful in chronic pain, and hopefully all of those will get covered, assuming there's some rationale. But that seems like a separate set of stuff from this bill, which is sort of the,
So if I could add to that, I mean, right now, if you look at the healthcare dollar, about 2/3 of the healthcare dollar, and I may be wrong, but at one point this was true, is basically out-of-pocket expenses for miscellaneous other things. Like rhino bones or whatever. I'm not putting that in the minutes, but anyways, so that's just people make a discretion that they're gonna a conscious choice that that's what they want to do, and that's fine. But they pay for it out of their own pocket. The question we're asking here is like, what do we expect, or what will we like insurers to cover? And I think some things are a bridge too far at this point, and maybe down the road, like if we have licensed Qigong therapists and they have really a more organized educational program and we have more evidence based, then maybe they would be included in this down the road. But at this point, that's lacking. And so, that's why at this point we don't feel, and this is like a big, broad group of people that discussed this and how we came to that conclusion.
I go back to the issue of the gatekeeper. It sounds like the gatekeeper is not the patient, it's going to be the insurance company. And that's my concern, is that we're now basically turning it over from the patient, even though we're saying it's patient-centered, it comes back to it's insurance-centered. So therefore, I'm trying to balance the two and saying, how do we ensure that it's truly patient-centered and not something through prior approvals and the gatekeeper really becomes the insurance company and not the patient and the provider. And I don't know where the line is drawn, but philosophically, that's kind of what I'd like to get into this bill, is that we have a balance between the two. Where that is, I don't know.
And Representative Murphy.
Thank you. So the bill that you sent to us has a lot of what Representative Weber is referring to that has been already deleted. And the reason I mention that is because if I read this bill, it becomes very succinct and becomes very explicit as to what we're talking about. So referencing Representative Merchant's question, I, as well as a provider, don't agree that it should be the purview of the insurance carriers to basically mandate what is covered. Having said that, if you look at page 1 of the one that you sent out to us, page 1, the patients seek treatment for myriad conditions that cause pain. It should be maybe a certified healthcare provider. So again, it is a healthcare provider that is basically certified. And unlike the days of past, a lot of the education now for opioid management, particularly in the last 20 years, is now incorporated in, provider education, grand rounds, et cetera. But it's also provided, and also there's a check in the recertification process. So if you want to back up to my, again, as an orthopedist and a very simple mind and a lot of this stuff, I would basically make the provider the gatekeeper in this sense, whether it's the orthopedist, the primary care, whomever it is, that it's a certified individual that refers to any one of the other options available. So that could be part of a bill. And it could be one that is also incorporated in the physician or provider education programs that they have available to them. The second part of that then becomes the insurer. And that is addressed, again, in your new copy of this, which has deleted so much. But I do have concerns, and I think the insurance carriers would also agree with me, that the insurer is then mandated to provide a lot of what is, prescribed by the prescribing physician or provider. But they mention in page 2, you mentioned in page 2, and you mentioned again in page 4, that each insurer, whether it goes from, on page 2, 3, they have to basically submit the insurance, to, or the coverage to the, HHS. I agree with that. That each insurer also has to supply and produce, and again, this becomes a bit onerous on the insurers, and I get that part of it. Produce and supply with each renewed insured issued policy, educational materials. The educational materials I don't have a problem with. Providing providers to do that is a different thing altogether, but is included in here as well, because it says in Roman numeral 6, they shall ensure an adequate number and type of licensed professionals. That may be a bridge too far and difficult for a lot of people to get to. So what I'm looking at here in my simple mind is, what does the gatekeeper, the provider, is mandated to do? I don't like to legislate healthcare delivery, but on the other hand, if we have something that says they at least should, through their educational programs, mandate, or they should, prescribe or offer as alternatives, that'd be one thing. But then again, the insurance carriers have significant burdens that are, placed within this bill as well. So I think we have to try to resolve those, is what I'm saying.
Can I ask a pragmatic question? Is this recorded?
It's on live stream, I believe.
So in other words, because you just said a lot of good stuff, and I didn't write any of it down because I wanted to hear it. But if I can go back and watch a recording so that we
I'm
can
just
make
trying
sure
to
this doesn't
simplify
get
this
lost.
to the
Yeah.
mandates that we are legislating for the healthcare provider, which I would agree, I think is important, but I think a lot of it is covered now currently in maybe some of the bills that were previously brought up did not recognize this, but there is a lot of educational stuff that's out there, and we all know there's providers that basically covers the provider's knowledge base and also their prescribing techniques and also providing alternatives to care. But again, I want to be sensitive to the insurance carriers and what is mandated in there as well.
So to me, this is like a carrot and stick thing. Like in the medical profession, we're being carrot and stick that we have to use an electronic medical record even when we don't want to because they're cost inefficient and they destroy private practice. So they're using that with us. To me, this is, I'm sorry, us, you guys, them thing, but this is important. Right now, what a lot of us in the medical field don't understand is, you can get access to this drug, this surgery, that injection without any problem, and the insurer will cover it. Much of that doesn't have any evidence base at all, but they still will cover it. However, we have evidence that chiropractic helps, acupuncture helps, cognitive behavioral therapy helps, massage helps. We have licensed practitioners that provide those services. We think that they're cost effective. We know that certain types of surgeries are not cost effective. So what this, if it requires a mandate to level the playing field so that people have access to all these things, all provided by evidence-based licensed practitioners, then great. But in an ideal world, we don't need that mandate, that people will recognize that these things have value and then they should be provided and they're cost effective, and we can actually maybe decrease costs rather than increase costs. And the next question then becomes, well, what's the forces that are causing the status quo? And that's a question I'm not answering here today, but I've asked it. And so, that's when I think when we get down to mandates is like, well, why aren't you doing this? And yeah, everybody has said, well, we do offer this, we do offer that, we do. Yeah, well, you do and you don't. And, I can get back surgery tomorrow, and even if I don't need it, I can get it. And you'll pay like $100,000 or whatever to get it. That doesn't make any sense.
So it does not only doesn't make sense, it's not cost effective. So the chiropractors have saved our butts many times. The physical therapists have saved our butts and saved the insurance companies a ton of money by taking care of their shoulder or the elbow, whatever it is, with a non-surgical approach.
Right.
As we all know, medicine has changed dramatically, and I would go back to the mid-90s when the RVU system came out. I think that was horrific. Having said that, it still is, you know, the carrot that is driving a lot of people to do surgeries. And when they could go and have, you know, something done non-surgically without a medication, or maybe just with physical therapy, whatever. But what I'm saying is that I would try to distill this bill down to what we truly want to think about as far as mandating, if at all, what providers do. And I think they do a lot of it already.
Yes.
But also then, you know, make sure that, you know, that is offered to the patient. That's where the patient-centered part becomes very important. That they are now part of the discussion that acupuncture, physical therapy, et cetera, is part of their treatment modalities.
Can I ask a simple, sort of digressing for a second, but I'm going through and looking at the one that's in the black, not the one that's in the red. It has on the top of it, House Bill 554.
Oh,
I'm reading through this and read through it before, but it reminded me. When I look at line 11, it says we have to try things before you can prescribe an opiate. Then it goes on and talks about nothing section and so forth. You have to exhaust everything before you can write an opiate. But then you go down to line 21. It's a conflict. It says nothing in the section shall preclude a healthcare practitioner from simultaneously prescribing an opiate or prescribing or recommending any of the procedures set forth in paragraph 1. So therefore, when I read through it, I'm not a wordsmith here, but if it says here I could write an opiate anyways, then why do we say you have to do all these things? It's kind of a conflict in there.
it was
trying
the
to resolve
purpose
it.
of striking all that.
Well, I'm just trying to understand
Yeah.
from writing the law, we sort of have built into it a conflict. At least I see it as a conflict, but I'm not an attorney. So I'm looking for somebody who's got more legalese than I do.
I have more legalese, but I only have the copy of the large thing with all the red and the black. I don't have the thing that
It's actually right over
my
there.
colleague to the right is working off of.
What he's reading from is actually page 1, and
But
it's
I
the
hope
it's the
that
stricken part.
you will agree on a particular template to work off of and keep the notes on one.
I would like to work off
Yeah.
the one with the red and the black. Yes. Well, I mean, that's in there, it's just struck.
So
what
this
we-
is now the one we're not working
So
on.
what we did was we took the original bill, and this is where the
this
challenge
is the
becomes,
original
is we
bill.
took the original bill, and then we put together a multi-stakeholder ad hoc group.
Right.
And then we
No.
rewrote it, and what's left is I kept some of that.
Let's just go back to first things.
Yeah,
We have pieces of paper in front of us.
yeah,
This is the original bill. It's all in black.
yeah.
This is the other thing that I was given, which is some black and some red, and it's very thick and it's
That's what we're
bits
working
crossed
from.
off. But it's not what has just been referenced by several of the
Correct.
last few speakers,
Correct.
which is a completely different document.
Correct.
And I'm just hoping that instead of talking about page 2 on this document, I mean,
No,
pick one, stick with it, and get it to the point.
My
Where it's what you
intention of
want.
this discussion is that the only piece that we're dealing with is with the one with the struck stuff and not struck stuff. And certainly you're welcome to unstrike stuff, but that's what we're working from. Does that make sense?
No, I just want to know of these two documents, which one you're using.
I'm using the one with the red and the black.
They both have little bits of red and
Yeah.
little bits of black. This is
I don't
one
even
with
know what that
editing
one
on it,
is.
You sent that.
Talking about this.
and this is one
Oh, all
that
right.
is red.
The one I sent you is actually the same thing.
It is, it's just
Okay.
in a
Yeah.
different format.
Okie dokie.
That was one that I sent out in a Word document to all the members of the, yeah, got it?
I'm just trying to get everything.
But what Representative Merchant reference, yeah, what Representative Merchant reference was the bill that was stuck in front of us today. That's not what we're working from. Thank you for that clarification. I didn't realize when I sent it to you it would come out differently.
It's very easy to read.
Yeah,
Mr. Chairman.
yes, Representative
To
Chairman McDonald.
Representative Murphy's point, obviously this is a complicated issue and we've we're getting a little confused here. But if I may reference another bill we just experienced, that came over from the other body, SB 440, that whole optometrist thing. Much of the problem with that, it was so complicated, so confusing, their objectives weren't even clear. And I sat in numerous meetings about that. We've got to make this as straightforward as possible if we're going to be successful. And the simpler, obviously got to address everything properly, but it's got to be as straightforward as possible if we're going to be successful in getting this passed.
I think the other thing that confused me a lot, because when we created a bill that was like a page long, and then all of a sudden it goes in to be written up and it comes back 1,000,000 pages long with references to multiple places in statute, and that makes this even more confusing, because basically all it is one section struck and two things that are functionally the same thing but written 2 or 3 different times. And so it probably would be helpful to just kind of focus on page 3, starting with line 13, and that's the thing, that's the gist of everything up to page 4, line 31. That's the entire gist of the entire bill, but it's repeated twice. Does that make sense? Because it totally confused me. Even this morning when I was re-reviewing it, it totally confused me, but that is what the new section of the bill is. One of the other reasons, because Representative Lundgren did an awesome job of doing this and bringing it to our attention and forcing and pursuing the issue further. The problem was getting multi-stakeholder support. So, that's kind of how we got to where we are right now, is taking what you started, putting it into this format, and that was what was able to get multi-stakeholder support. And then with the insurance companies, input is how we got to the licensed element of it. So why we limited it to licensed people, the number of things that we argued about or discussed about it, that we still are open, to question on their part, I'm sure, is, the number of treatments you should provide for each of these things, may versus shall, that kind of thing. Because we had that was a huge discussion, like, should this be may or shall? And those are things that are in this bill. In fact, I have it in there, may or shall, one's in parentheses, one's not, because that's an important discussion point. One of the other issues is that they claim that they already provide these services. And then the other little minor detail is it only applies to 22% of the insurance industry, which is a huge problem. Anyways.
So I just want to make my 2 cents about the may versus shall. I assume that they may do all of these things right now. And as you just said, many of them are doing some of them already. So if you're going to have a bill, saying that they may do it is not actually doing anything. But certainly shall is going to set people off and make it much more difficult. But my concern is always that we often have bills that are described as feel-good bills, where we say, somebody might be doing something, well, that's great. But people are either already doing them or they're already not. So if you're actually going to have a bill, it probably ought to be a shall.
That was my opinion as well, and I appreciate that statement. Feel good's nice, but it doesn't accomplish anything.
Talking about the insurance companies again, is there a way to develop some way? Is double ways there. What I'm trying to think through with the committee here, if it's really patient-centered, is how do we somehow protect the insurance company from financial risk? Because a lot of times it comes down to is you're trying to measure and monitor, if you will, the risk you're taking on financially. Because you have X number of dollars coming in a premium and how you spend it out and so forth. You have to be cognitive of what you're doing on the expense side. Instead of trying to get into, which I don't like as mandates, is allow either the provider or the patient to have, back to like with hospice, there's some guardrails, financial guardrails on it, so that it just can't run amok. But there's also more leeway within it, So the patient at that point in time has, and along with the provider, has a little more say in how the resources get utilized, but the insurance company is protected from outside of the guardrails. So there is some sort of way to minimize the financial downside, but allow for the patient provider to have more flexibility in utilizing the resource themselves.
Representative Palmer?
So, I mean, most of the things that are listed now are not hugely expensive, like, not that physical therapy is cheap, but compared to surgery, it's cheap. I guess one thing might be that, and there are, I guess, for negotiation is whether it's 12 visits or whatever it's going to be for a given thing. So then the issue about how it might get out of hand would be if you have 5 different options here, does a given patient get 12 treatments of all 5 different options, or is there some other limit that kicks in after you've tried? But the flip side, if it's patient-centered, if they tried physical therapy and that didn't work, shouldn't they be allowed to try acupuncture?
If I can answer that, because I want to just explain how we got to where we are. So the original bill actually basically said it wasn't a sky's the limit thing, but it listed a number of different entities within each subcategory. And the way it was written is there were 20 visits, not 12. And that person could have 20 visits of every one of those things. And when you did the final number, it was like over 100. I mean, it's a lot. And so, you know, the insurers appropriately pointed out that problem. And then the next number question was like and it's nothing against chiropractors. When I first started out, like, you know, I've been here for almost 40 years, but in the beginning, you know, we'd have patients going 3 times a week for decades. And the insurers were paying for that. So is that excessive as well? The number 12 was basically a compromise, and you could use 12 from each of those 4 categories. What's really important when we talk about patient-centered integrative care is, my favorite example is that when a little kid hurts themselves, you know, falls, gets a boo-boo, the first thing the mother does is gives the person a hug, then kisses the boo-boo, and then begins to do range of motion. They've now done 3 different modalities for one acute problem. And that's the way we treat things. So that, you know, acupuncture and chiropractic together may be a good thing to do together. And that's why it was important that you not limit 12 altogether, you know, that you could do 12 of this, 12 of that, so they could work together. That's where all these numbers came from, why we did it that way. And the 12 was a compromise because 20 would have been preferable, but that was me being nice.
One more thing, just
Yes,
getting
thank you.
back
Thank
to
you.
what Representative Murphy talked about, which was that the insurers will ensure an adequate number of providers. I mean, that. I guess you would want to make sure that they.
I'm sorry you didn't get to talk. I wanted to have you guys talk. Oh,
Can you be convinced to stay a minute?
thank you.
Did you want to say anything?
I'm loving what I'm hearing. Very positive. Even Jerry Merchant.
I just wanted to thank you again. It was really important. You kept, because you're welcome. I'm sorry.
So, well, just about that, because I mean, if you said that an insurer will ensure the appropriate number of primary care providers, I'd go like, well, everybody's trying to do that and nobody's succeeding. So I guess I'd like a little perspective on that, because I guess there needs to be something that says, well, we're going to pay for it, but we don't have any acupuncturists on our preferred list. So essentially, I don't know.
I'm really glad you brought that up, because you guys are bringing up all the questions that I had without me having to bring them up. So I personally would strike that. It was what was the USPF wanted it. US Pain Foundation wanted that language in there. In Massachusetts, it may be doable. In New Hampshire, it's probably not. I thanks for bringing that up.
Thank you, Mr. Chairman.
Oh, sorry, Representative Murphy. Sorry.
Just a couple points while there was a lull here. I wasn't sure I understood should. When we get to shall and may, I understand, but should threw me way off.
No,
Should, so that was one of the questions I had. The other one I had was, if you do multimodal and you want to put a definition in there, and you put synergistic or complementary effect, it may be good to put in there alternative effect as well. And the reason I say that is because behavioral health interventions is entirely different than manual interventions. So, they may not be synergistic, but they may be alternative. So I would just add that as a suggestion, not necessarily to wordsmith it overly so, but just
Can you
add.
say that one more time? So I want to make sure I understand what you just said.
I would add in multimodal, it talks about synergistic or complementary effect. I would also say, and also alternative.
Okay, gotcha.
And the reason being is because behavioral is different than manual therapy of different sorts.
You guys are like the best. This is fun.
So are we replacing should with shall or may or both?
Shall.
What,
I mean, it's a waste of time to do this bill if it's not shall.
Right. Good.
but Representative Murphy, where are you on which page?
Again, I'm working.
4
The red one.
the one that looks like this,
Mm-hmm.
and it's line 30 and 31.
It's interesting because, and I want to just emphasize that everything that I try to do in healthcare when I'm running symposiums or whatever is that we always include a patient, at least one, because last I checked, they're the smartest people when it has to do with their own body. And that terminology and that came from patients, not from us. So that's why that's important. But I agree, all changing that's fine. This is a lot of information, and I mean, you've pointed out all my. Oh, sorry. No. Did you want to? Because I'm trying to think of like where we go from here. This is a lot to throw at everybody here at one time. I didn't intend this to be a last step today. I don't know how you all feel about that, but this is a lot of information, good for stuff for me, and it's virtually everything you brought up is stuff that I was thought about or concerned about. So
I would suggest that we do go forward. I'm sorry that we've given you so much information.
no, it's what I
basically
wanted.
manage. But if I had two things in my mind that would, and I'm thinking about, as Representative McDonald mentioned, when we get to the point where there'll be a vote on the floor someplace or in a committee somewhere, it's going to be very important that we address the responsibility of the provider and also their education and their recertification and their education that's already done and what they do already. But also to make sure that the insurers are part of the equation.
Yep.
And, in my most simplistic terms is that if a licensed non-quack, provider offers an alternative to opioids, then the insurance coverage should be there to make sure that it's covered. That would be my simplest, and that'd be my one-page summary document.
In the last 5 days, I've been called all sorts of names. Yes, and in my medical career, I have been referred to as a quack at times. I started doing epidurals in 1987 for back pain because I thought it had value, and I know a prominent doctor in this state referred to me as a quack, who 30 years later I actually did an epidural on. Right. So I always struggle with the definition of quack, but yeah, I get where you're going.
Yeah, mostly I was saying the non-quack, that the people that provide the healthcare do the appropriate thing.
Representative Weber.
And I'm just going to remind everybody here that this is a very productive discussion. But when we get to what we do as a committee sometime between now and October 20th, the only thing we will be voting on is recommended for further action or not recommended for further action. So if all of the wordsmithing is not done, that's okay. I always think it's helpful to have subcommittee meetings where they're open to the public, people can come, people can listen, and, sometimes it's not pretty, but it's helpful in terms of input and openness of the process. But if the words are not completely smithed by the time the committee meets, that's fine. And of course, going forward, the chair can certainly appoint whatever ad hoc subcommittee the chair thinks is valuable and useful. Always
So,
remembering that all of our personnel is going to change on December 5th.
so you just segued very nicely into what I wanted to ask all of you about, because everybody here has more experience than me. But when we did our prior authorization bill, which I was told had zero chance of passing, it was a waste of my time. And I said, well, it's important. One of the things that we did that I think guaranteed its success was that we put together an ad hoc group that included, and I think these are very similar issues. That's why I think that you can superimpose them. But the group included the Hospital Association, the Medical Society, the two sponsors, which are me and Senator Ricciardi, the Insurance Commission, and the insurers. And we sat down at a table as equals and hashed out this bill. What makes sense? What doesn't make sense? This needs to get done. How do we do it? And how can everybody be as happy as possible? One of the reason I wanted to direct it this way at this time is I really think that needs to happen for this bill to be successful. Because I'll be honest, if we eliminate the insurers from the discussion, this isn't going anywhere. And that's a waste of time.
And that process can happen in one of two ways. One of which is that you and other private citizens can meet with anybody you want to meet with at any time, without any notice to anybody you don't want to notice, but including everybody you want to include. And that's just a private meeting, and that's no problem. If it is an actual subcommittee, as this is, appointed by our chair, then we are subject to the right to know law and the notice requirements. So there is nothing that stops a group of interested people from meeting as many times as they wish to meet and discussing ways and means and seeing if they can come to a consensus, which then gets filed with OLS either in November or as an amendment to a bill filed in
The other
November.
thing we did do is, for strategic reasons, we actually put the bill into the Senate, so that would give us more time anyway.
Perfect.
If we chose to do it that direction, yeah.
If I could follow up on that, if it's a private meeting, at that point in time, can that be done online, virtual versus being in
If it's a
person?
private meeting, it's a meeting of private citizens, and they can do whatever they want to do. If it's a meeting that is a House meeting, we have to do it in accordance with our House rules and with RSA 91A.
So from the insurers and the audience, I think, Larry, you were there, right? Were you there at that meeting that we did for prior auth?
Yeah, I was there.
Oh, Andrew, I know you weren't, yeah. I don't remember it. I'm pretty sure it was a noticed meeting, but I could be wrong. But it was held, at the State House.
Well, we've had a number of different forums, fora. One could be a statutory study committee,
Yeah,
which is created in chapter law, and also those often bring together many different people wearing many different hats. This is a retained bill committee, so the only people who can be on the actual committee are House members, but you can, of course, listen to anybody you want to listen to. So it's possible that it was any number of these things, but there have also been any number of very good bills brought to us that have been the subject of a lot of meetings outside of the legislative process by people who are interested and who are stakeholders who are trying to come up with something which has a chance of getting through because they have sat down and discussed it carefully before they started. And so there's merit in all of those.
So, because this is what I'm sorry, Representative Murphy.
So I have more of a question than anything else at this point, and maybe the insurers can help me with this as well. If you have, and I'm trying to get at the heart of the bill, which is really to, as you mentioned from the outset, as a response to the opioid crisis that we had and we still have going forward. If you have a licensed, certified, credentialed, privileged provider, I didn't say anything about quackery, but if we have a provider that offers an alternative to opioids, has that been denied by the insurance carriers? And the reason I ask that is because, it gets to the point that if I provide a service and I choose not to do surgery, but I provide something that I think would be very effective for the management of that patient outside of the surgical realm or the opioid medications, have they been denied? So the question, the reason I ask that question is that if you have the right person providing the right alternatives, has that been then denied by insurance carriers and therefore the genesis of the problem that we have right now?
So
That's why it's almost a rhetorical question.
Yeah.
But that's the part that I want to get at in the bill that should not be arguable.
Well, what's been interesting historically, and you and I have been around a while, and but when I first got here, chiropractic care was off the charts. I mean, a lot of our patients were going every couple times a week, if I remember right, and now it's like feast to famine, and that's what a lot of the chiropractors, and that's why this bill came from them. A lot of the other entities, it's really interesting because the minute you accept insurance, you accept everything that comes with it, like prior authorization and all the headaches and all that kind of stuff. So a lot of the groups that I work with, they don't have anything to do with a bill like this because they're very happy living fee for service at low cost. So but yeah, I mean, massage isn't covered by almost any, and we know it has benefit. Chiropractic is covered by most insurers, but it's very limited compared to what it used to be. Acupuncture to me is almost a joke. I mean, like CMS approved it for chronic low back pain, which is the one thing it's least likely to help. I mean, it's like, well, yeah, we cover acupuncture. No, you don't. You cover it for something that it's not going to help. And CBT has always been really challenging, like, mental health interventions and things like that. And we know especially for chronic pain, CBT cognitive behavioral therapy has a lot of value. And getting access to that is really hard. So, and to be honest, it's a lot cheaper than a lot of these anti-inflammatories are. Yeah. I wasn't even gonna go that far. So to answer your question, yes, that was the genesis of this, is people don't have access to these things. And some of them, that was the one that always bothered me, is like I made a deal with an insurer a long time ago about acupuncture. Basically, the only patients that they allowed me to treat were people that exhausted everything first. And I said, the patient I'm most likely to help is the patient I see before it gets to be a problem, not way down the road. You've basically just guaranteed that I'm not going to help any of your patients, and then you're going to conclude I'm useless. When if I had done it here, not there, and that was the other thing, is timing is critical. It's you don't want to do these things. It's like anything, you don't want to do it too late. You want to do it earlier. So timing is important and access is important.
Well, I'm glad you brought up the point about timing because, you get into a chronic pain situation and no matter what you do for that patient, it's not going to be helpful. Whereas if you were to take care of that problem right from the get-go with the appropriate therapy, that may be very helpful, and that includes, therapy.
It's interesting because if the National Pain Strategy was one of the greatest documents ever produced by the federal government that never led to anything, and it's not that but basically they put together was a group, and I was kind of involved in it, but, you know, we came up with 6 pillars of pain strategy that we needed to get on. One is early care, is timing and prevention of chronic pain before it starts. And if you don't have access to these things earlier, then you may have a higher incidence of chronic pain, which means that you're going to be stuck with very costly things forever. So prevention's important, but it's the one thing that very difficult to prove it's successful. And at the same point, even in virtually every element of our healthcare system, prevention is the one thing we do rotten. So, anyways, this is fun. You get to babble about stuff.
I hate to say this as a surgeon, but I would say that, what we've come to realize is that oftentimes the things that we are most likely to benefit from substantially, education, healthcare, whatever your beliefs are about climate change, et cetera, if you do those today,
Yeah.
they have significant impact, not 5 years from now in the election cycle or 4 years or 2 years, but 30 years down the road.
Exactly.
The same thing with healthcare. So if you provide that healthcare early on, the insurers would actually see a benefit financially as
Yeah.
well.
Totally. So I guess, Representative Weber?
I just had one more drafting thing, if I may go off the board, because I was rooting around in the statute trying to figure out why we needed to do this twice, and the answer is one is individual and one is group.
Exactly.
But I do have one further suggestion, which is that in normal statutory drafting, you put your definitions at the top rather than the bottom. So when somebody actually gets to the point of drafting something for OLS, you might make sure that that goes at the top rather than the bottom. And then I leave to them remembering which is a section and which is a paragraph and which is a subdivision and all the rest of that. They'll work that out for you. But putting it at the top is helpful in terms of understanding what comes behind. And it's where people will look for it.
So I have a pragmatic question that's kind of related to that. So this is what if this wasn't a legislative meeting, what I would do at this point would say, you know what, we've discussed this, we've given this to you. Can you look through the draft? Tell me what you think changes need to be made. I'll make the changes and then we meet again to go over that, make sure I got it right or we have it right. And then because I have to submit a report, I think in October 20th.
Before October 25th.
Yeah, so we have time, but I was just thinking we could meet one more time, and then come up with a strategy. But it might be helpful if people could do that, and then I'll try to take.
And
all
if
your
there's somebody here from OLS, they can correct me if I'm wrong. But my understanding is you're perfectly okay with the right to know law for everybody to send you their thoughts and you can put them into a draft. You need to then not discuss it back and forth between everybody on the subcommittee until you get to your new meeting. So everybody can send you their thoughts and you can consolidate them, and you can certainly send that out saying, here in preparation for our meeting on Thursday is a draft that includes everything I've been sent. But then you have to refrain from saying, oh, and we're all going to, as a group, discuss it back and forth, which is entirely counterintuitive and one of the toughest things for new legislators to learn, because it's how we all work outside of the legislative process.
So if we could do that, I would appreciate that. But I would like to, I mean, I know we have more time, but I would like to schedule, another meeting to perhaps finalize that and get next steps. I have another question on pragmatics. So, because I know when we tried to do an ad hoc thing with HB 66, we were told that if there were more than so many members of the committee present, that it would be functionally an illegal meeting. So in other words, if we put together an ad hoc meeting with insurers and whomever, all stakeholders,
They all have to be less than a quorum
right?
of a legislative body.
And so
So-
human services.
So if it's the Health and Human Services Committee, you can have, you have to have 10 or less.
Oh, we can do that.
But if you're 10 or under, you're home free because it's a 20-member committee.
Oh, that'd be,
And a quorum would be 11, so you're golden.
so we should, okay, so so this is what I would like to do going forward. If everybody can give me their feedback on what they saw. Thank you for bringing up that wrong thing about Qigong and whatever. That was helpful. And then we'll make a note. I'll go over this entire document, and then we're having a house meeting on the 10th, right? And that's more than 2 weeks away. What day is today? I mean, could we meet in like 2 weeks to finalize that, and then next steps?
Well, Mr. Chairman, you were thinking about having our committee meeting as opposed to any other meeting, sometime the 8th or the 9th, which would be the committee meeting at which we vote either to recommend for future legislation or not recommend for future legislation. But we can do that in the absence of actual wording, because that committee doesn't vote on the wording. They just vote on the concept.
So here's a motion. Oh, go ahead, sorry.
Yeah, to Representative Weber's point, she and I were discussing earlier, I believe it's 13 interim study bills, and we need to get them out before October 25th. We're thinking having a work session and an executive session on, the 2 days before veto day, which is October 10th, and, trying to dispose of all of those.
Okay.
But if you're talking 2 weeks out from today, that would still be September.
That'd be like the 27th or something.
2 weeks from today is the 26th.
26th, so.
Is there a date that has been selected between October 8th and October 9th?
Well, we're looking at October 8th. If that works for the members of the committee, it's a little bit off topic for 554, but if October 8th works for you folks. No? Representative King, it doesn't work?
I have a conference both the 8th and the 9th.
Oh, okay,
I'm working that week, so that I'm not.
okay.
Yeah, I'll be out of town. I'll be back on the 9th.
I can't do the 8th, but I can do the 9th.
Actually, no.
Okay.
Yeah, I'm like Representative King, I'll be out of town that week.
And again, it's
Definitely.
not gonna be like normal executive sessions. It's not gonna, the bill isn't gonna go to the floor or anything, so it's not a huge, I'm not saying it's not important, but it's not as paramount as other executive sessions would be, because we'll either recommend for future legislation or not, and even if we don't recommend, they can still be brought up, so. All right, so I guess we may have to go to the 9th, from what I'm hearing. I don't know. And again, we can adjourn by 3 and call another meeting after, following week. Because I am respectful of the fact you have another meeting at 3, so,
So,
even though I'm not invited to it.
so it's safe to assume, I don't want to assume, I'm not going to assume. Are we in agreement that something will come out of this legislatively?
Hope so.
Yes. All right. So, that's all you needed to know, correct? From us.
Well, as I understand it, the interim study committee report, and it does need to be one, even if it's as simple as saying not recommended for future legislation, the more we can put into that, the more of a head start it gives the bill next time.
Okay.
And given the challenges, and I don't know the history of this bill as well as some of you do, but it sounds like it's faced a lot of challenges in previous efforts. And the more of a head start we can give the bill next time, in the next session,
Yeah.
the more likely we'll have success. So
To
the
answer.
more we can put into that interim study report for the next,
Okay.
and the next effort, I think the better it'll be.
To get at some of Representative Merchant's concerns earlier on, there was the original bill had virtually no stakeholder support. Even the groups that it was designed to help didn't support it. And so that was the genesis of 303, was to actually, well, how do we actually get stakeholder support? And so how would that been in other states? We have virtually no other state model to go by except Massachusetts. And the outcome of that wasn't that great. So we tried all along to include the insurers in the discussions. So, you know, and I understand their concerns. I get it totally. But that was the genesis of what we got in front of us now is this is what we had got stakeholder support for. So virtually every stakeholder supports what we're proposing, except maybe the insurers. And so the next question is like, how can we work with them? And I also, with that said, you know, this is my world, this is the way I think, but every insurer in this state you're the best people on the planet. You guys are wicked awesome. You're the best people ever. We're not necessarily legislating for you, but we are legislating for other insurers that may migrate into this state. And as I think, and again, I will reiterate what I've said before, is that there's a concerning trend that in the next 5 to 10 years, there will be 4 to 5 providers of health care and 4 to 5 insurers for the entire country. And if we don't get control of that now, they will dictate to us when they get here. And that's really important to me because, I mean, the death of private practice is the absolute worst thing that's happened to healthcare in the last 40 years, in my opinion.
I just also want to plant the seed in people's minds that it's very likely that a newly drafted bill will go to Commerce
Yeah.
rather than to Health and Human Services because they do the insurance pieces. So as you are considering who to talk to, talking to folks on the Commerce Committee and making sure that they are involved in the process is going to be key to success.
I actually already reached out to some certain person that you know who I'm talking about to talk about it. We apparently did not connect. I think this little thing called an election probably got in the way, but yeah, I did reach out to him to talk to him about it. And I think he would applaud the concept of trying to bring everybody together to do this because it won't work otherwise.
I'm not sure who the individual is, but if it's the same one I'm thinking of.
I'm sorry, it's Representative Hunt. I should be like
Yeah, okay.
blatantly
I
obvious.
suspected as much. He hasn't been too sympathetic to this bill previously, but
I mean,
if you're making inroads, that's great.
for whatever it's worth, I wasn't either, but I saw the merit in the concept, but the bill itself was greatly flawed. And so, you know, when I found out the chiropractors didn't support it either, I was like, oh my God. So like, all right, it's a good concept. How do we fix it? So then I just brought in people way smarter than me and we just sat down and tried to figure out how to make it better. And it still was greatly flawed. So, but I think what you got in front of you is better than what we had done before, but it needs more work.
Again, the simpler, the more straightforward, the better, I think.
So a 39-page cannabis bill that's too short, right? We got, when we passed our prior authorization bill, the CMS proposed the reforms within 3 days of us going to the Senate, and our bill was about 6 pages long. Their reform package was 850 pages long. So, I thought 8 pages was too long. So, all right, this was great. Any questions? This was wonderful. I never asked anybody from the public for comment. Do you guys have anything to say, Ed?
Representative, I didn't have anything to say. I just wanted the definition of chronic pain.
Yep,
And how about the last 4 words, lasting more than 3 months?
we got rid of that.
We got rid of that.
Yeah. I mean, the reason why was we're not just talking about chronic pain. So we're talking about pain in general because, you know, all these modalities can be used at any part of the treatment process. So it didn't seem to make sense to me to differentiate for the purposes of this bill. The other work we're doing, as you know, that you're very involved in, we that is an important differentiation. I think, unless anybody has anything else, Representative Merchant.
Is it possible to receive a document that is not red and black, but just black, so I can look at it and not try to get confused between what I'm trying to ignore and what I'm supposed to pay
I
attention
will
to?
send it
It
to
would
you.
help me immensely. Thank you.
How about this? Now that I know all of you are involved, I will send a unredacted copy to all of you.
And I'll apologize for having gate crash because.
No, it was, you were really helpful. Yeah, no, nobody should ever apologize. I mean, Representative King was probably the most helpful, because I kept looking at you going, what's he thinking? And I'm like, oh my God.
Mr. Chairman, so the copy that you're gonna be sending out next will be all black, but all the redacted stuff won't be in there at all, right?
Correct.
Okay.
Unless you hit markup, I guess, right?
Send something that is drafted the way Legislative Services does it. Start with the language that's there in the statute,
Okay.
cross out anything that's in the statute that you don't want to continue on.
Okay.
But
How about if I send you two separate copies? One that's totally as you requested, and then,
it's up to you. I mean,
Yeah.
it just, I think for a lot of people, they're used to reading the way OLS does it.
yeah,
And they start with the statute, they cross out anything that's going,
yeah,
and then anything that's new
Mhm.
is bold and italic.
Yep.
And that way you can see
Good.
what is completely new. And the thing that's always complicated with that is if it's a whole section that's staying, then it stays in regular print. You don't realize that it isn't new until somebody tells you, but it's just easier that way.
because what I sent you, and I'm not gonna organize, like you said, definitions, I'm just gonna leave it where it is for now. But yeah, that is what I sent you, was what I wanted to leave and what I wanted to
Just sort
stay.
of do
Yeah.
the language that you want and leave somebody else to deal with the statutory stuff.
And just so we emphasize, it's not a me thing. This bill was actually worked on by about 7 or 8 people, who do this work locally, regionally, and nationally. So this wasn't just a me striking this or striking that. We did it as a group. So, and this was an ad hoc group, and this was done like at least three or 4 years ago. So it wasn't recent, but because the same exact bill was presented 3 different times.
So what I'm hearing, so I'm clear about this, I'll receive a document, you'll take all the stuff out that's redacted if you want to stricken.
Yep.
And I'll have at that point in time is a clean document. I do understand where Representative Webb is coming from. But once we're trying to get back our comments, you're going to collect all those comments eventually, and then we'll come back and talk about the comments collectively. Is that where we're going sequentially? And then once that's done, that will go on to OLS, and they'll take the document and go through the process to strike out what's being removed out of the law, and then bold and italicize, if you will, that's being added.
So
Is that the sequence I'm trying to get through?
well, the OLS might be like a step farther at this point, but
I wouldn't worry. I don't think we need to worry about OLS at this point, do we?
exactly.
You will have to worry about OLS
On November 12th.
during the period from the day after the election when things open to whatever the date is that it closes, because that is our only window of opportunity in the House. There is a larger window of opportunity in the Senate, and that may be the reason for doing it through the Senate. But you can't just say, in January, we're going to go to the Rules Committee and have them bring it in, because the Rules Committee has always said, if you knew you could have brought it in November and didn't, sorry, wait for next year.
So
So,
just to get even farther with that, I mean, the purpose of this interim study committee was basically to say this bill has value, we're going forward. The next step is one of us has to write a bill. And that'll probably be me or David or whomever, Representative Lundgren or whomever, but like, there's a space there.
Is this going through the House side or the Senate side?
I haven't decided that yet. I can see good reasons to go either way. I actually reached out to a senator friend to talk about this today
I'm
too.
also assuming Senator Birdsall remains chairman of HHS. We may want to bring her in then.
That's exactly the direction I was thinking of going. Partially, one of the reasons why, I mean, it was so much easier to do, like, when you guys weren't there, but like you were there, right, Heidi, when we did the thing on the prior auth, we had that, the big meeting, because I thought that was helpful, right? So, because I don't know if you were here when I said that, but that's what I wanted to do with this. And, but to do it through the Senate, like, I mean, Senator Ricciardi just told her secretary and the whole thing was arranged. I mean, it was just pragmatically a lot easier. And then the committee, it got assigned to was a lot more proactive, and we were able to make amendments to the bill that, you know, in the process that allowed us to get it through the House, because I think if we'd gone to the House first, it would have died. So, and in the end, I think everybody's better off. So I might do it that way, but I might not. So all we need to do, yep, yep, yes.
Do you have a list of the?
That was him or me.
I know, this is fun. We're like twins.
Because if I'm on the 1 o'clock, I'm not mistaken. If I'm not on the 1 o'clock, I have other things that I need to do.
I don't,
Hey, Gary.
I
Hey, good afternoon, everybody, and welcome to the work session for the subcommittee on SB 495, which is relative to the certification of alcohol and other drug use treatment facilities. So welcome, and before we begin, just like everybody to stand, and Representative King, would you do the honor of leading us in the pledge? Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, thanks. So, I do believe on the table there was a copy of the agenda. And basically, this is just a rough guideline of some questions that I had in my mind over the summer. Our former committee researcher did some research, so I would kind of like to begin the hearing, kind of going through and soliciting any feedback from members of the committee or any of you folks, if you would like to kind of make comment on what we're doing in other states. And how we kind of compare here. Also, you can feel free, when we met in June, everybody just kind of moved up to the main table if you think you're going to have a lot to offer, rather than having everybody just coming up to the witness box, as it were. If we get into a discussion, feel free to migrate up and fill in the empty seats, just so that we can kind of keep things moving. We are going to lose Representative Weber relatively early, so what I want to do is kind of get in right away into looking at some of the work that the committee researcher did, and with some deference to getting some of her questions answered before she has to leave. So, yes, Representative King.
Before we go too far, my main question is, what's the purpose of this bill? I believe the background behind this was that somebody had abused a client at an agency, or not an agency, but a reform house or whatever. And this bill is trying to do what to alleviate that in the future?
So my understanding from the testimony and from what we talked about when we had the initial meeting in the fall, and everybody else can feel free to speak up, but there's a couple of issues. Certainly, one of the things that was offered in testimony was they brought up the NHPR podcast, the 13 Steps, where there was an abuse of somebody that was going in for treatment. And so, what can we do to mitigate that? But in addition to that, also, when people come and they're going to get treatment, how effective is the actual treatment itself? So this was not just, I don't believe, to look at addressing the abuse issue, but also making sure that when you have an opportunity to get somebody into treatment, that we put some guidelines in place that treatment is going to be as effective as possible. Some of the feedback that we got from the folks in HHS as well is they're trying to kind of understand the landscape of substance abuse treatment. And so it's my understanding that if the facility is getting Medicare or Medicaid, then they're kind of bound by that rules. They're registered by the department. But if you're a nonprofit or a for-profit and you are basically not taking Medicaid, then you're kind of off the radar. So there were a couple of different irons in the fire that this bill was trying to get to. So anybody else have any additional thoughts on that? Representative Weber?
Well, I'll defer to Representative Shapiro on this because he's one of the sponsors, but the potential revisions that we had in the copy of the bill that you handed out to us, I believe, limited the facilities to outpatient facilities because we found in committee that there were so many different kinds of facilities that it's not a one-size-fits-all in any case. And I think that my recollection is that what the committee then hung up on was the issue that practitioners who are providing services are licensed or certified to do whatever it is that they are doing for a service. And the question among committee members, and I'm remembering this coming particularly from Representative Merchant, was as long as the providers are certified, why is it necessary to certify the facility as well? And the committee as a committee had to plow old ground, had reviewed the issue of sober homes in the context of them being places that were unregulated, and therefore that was brought to us as a concern by the fire EMS folks, that the conditions in which people were living were simply unsafe. But I think that there is concern that facilities that are completely unregulated may not be dealing with people in an appropriate manner. And I think the question for us, or for me at least, is if it's an outpatient facility where people are seeing licensed practitioners, I am a lot more comfortable not having a certification on the actual facility than I would be if people were living there. But I think one of the things that the hearings pointed up was the depths of my ignorance of the whole subject. And so I'm certainly keeping an open mind and can be persuaded either way. But I just wanted to be sure that we understood that the bill that we're looking at as it is now is just outpatient facilities. And that may be the way we want to go. We may want to do something else, but.
Yeah, and that is correct, because there is a separate bill looking at sober homes. Representative Shapiro?
Yes, I think when the bill first got introduced to us, there was a lot of confusing things in it. And it turns out that residential programs were not included in this, and that's where the alleged abuse happened.
Right.
And they are already have some kind of oversight by the department. So I think at our committee, probably not accepted by everyone, but I think fairly broadly accepted that services that are provided to New Hampshire citizens should have, healthcare services should have some kind of oversight by the state. Whether that's strict or not so strict, I think that's broadly accepted. And I think this bill was brought because there's a certain group of programs that don't have any oversight. And I think at our committee, we got into a discussion about facilities, meaning like buildings, or licensees, like licensed clinicians. And I think it is true that licensed clinicians already have oversight through whatever board they're licensed by. But I think some of these outpatient programs are not just, and I am certainly not an expert on this either, but certain of these programs, although they're called outpatient programs, they're not necessarily only individual counseling programs. So they may have people who are working at these programs who are not licensed, who do not fall under the Board of Licensure, one of the boards. And I think we're not talking about oversight over facilities or licensees as much as programs. Kind of like having some kind of oversight of whether a program is effective, whether there's misconduct, where somebody can go when there's misconduct. And so that's the other part of the bill, is to have an ombudsman to follow up on complaints. I don't I don't know if that clarifies anything.
Yeah, I think it does, and I've had a lot of conversations over the summertime with a lot of folks who are skeptical about the bill, and it all comes back to the whole OPLC versus DHHS approach, which is where I'd like to kind of mine a little bit deeper. I did notice if we go through and we look at the work that Ms. Dyer did over the summertime, where she was comparing different states. So I'm looking at Appendix C. I'm looking at a state like California, where they are going in and they're going after the folks who are, the service providers, as well as the facilities themselves. But then I go and I look at a state like Florida, where unless it's dealing with something related to the Department of Corrections, they're just licensing the providers. So it seems like there's a divergence. There's not universal consistency there. And so thinking, because a lot of the pushbacks, just to share with everybody, that I got back is, why not just go the OPLC, the OPLC route, and have, if everybody is a certified provider, and we're not talking residential care anymore, that's outside of the purview of this bill, would that not be adequate? And so with that in mind, I go back to Appendix Appendix B, that was done over the summer. And if you look, the only thing I see that, is a certified recovery support worker and a licensed clinical supervisor and a licensed alcohol drug counselor. So it looks like when I'm looking at Appendix B, I have all of these things that exist already. So I guess the question I would have for you folks is, even those facilities that, operate outside of the realm of Medicaid and Medicare, the folks that are employed, they still have to meet these criteria. Am I correct or not correct? I don't think so. You don't think so? Okay.
So I wonder, since we have Appendix A, types of substance use treatment in New Hampshire, if this is indeed accurate, I wonder if we could have someone from the department go through these and say which ones of these we're trying to address with this bill. And do they, and those that we're trying to address, do they in fact only have licensed staff at those programs?
Yes. Thank you.
All right. So hi there, I'm Jenny O'Higgins. I'm the legislative liaison for behavioral health with DHHS.
Welcome.
Thank you. So if we're looking at Appendix A and we're looking at program type here, what you're looking at is actually the different levels of care under the ASAM. And so high intensity residential and low intensity residential would both be licensed, right, by our Bureau of Licensing. And so they are regulated under the 826 rules of DHHS. Partial hospitalization is considered outpatient, and so that would fall under this bill. I'm looking at everyone's nodding with me, so that's a good sign. And outpatient and intensive outpatient would all fall under this bill. Medication assisted treatment, it can be at any level of care. So medications for substance use disorder could be happening within inpatient and outpatient settings, or through your primary care. So that's really across the board. Ambulatory withdrawal would be outpatient. Recovery groups would not fall under certification or licensure, nor would recovery community centers or recovery housing.
Those would not fall under this bill?
No.
Right, okay.
So recovery community centers and recovery housing, the department does help fund and help with quality oversight and everything of some of the RCO's programs. And there is a certification process in place for recovery housing, but those would be separate from this outpatient certification for treatment.
So my next question is, so those would be the kinds of facilities and programs that this bill would address, the ones that you just highlighted. So going into the B appendix then, am I in the right one? Yes, so going into the B appendix, it looks like a licensed alcohol drug counselor. These are all currently licensed with OPLC.
Yes, so when we were looking at the types of or levels of care, you're talking about licensing or certification through DHHS. These are individuals with a license through OPLC
Okay.
and regulated by OPLC. So it's sort of two layers.
So, and I'll just let me ask one more question, Representative Shapiro, and I'll get to you. So, are there any gaps in this list relative to the kinds of services that are being offered? So I'm looking at, this looks like a pretty comprehensive list of, like a recovery worker. You just can't be a certified, you just can't be a recovery support worker. You have to be certified. You can't just be a clinical supervisor. You already have to be certified. So those certifications already exist. Are there any gaps in the staff that, you can think of?
So it's not this, well, I'm sorry, I did misspeak earlier when I said oversight is listed in this chart, and I had said they were all overseen by OPLC, but you'll see on here Board of Pharmacy or the Bureau of Drug and Alcohol Services listed. So I just want to correct that first.
Okay.
Because I just broadly said OPLC, but there's a couple different layers of oversight. So certified recovery support workers are certified under BDAS. But it's not, the bill is not so much addressing a staffing issue as the outpatient care, right? And so the license, those who are licensed and working within that outpatient care, that regulation already comes under OPLC. But there isn't the quality of care oversight in the outpatient space besides those who are contracted with the department today.
Hi, I'm Sarah Cleveland. I work for the Bureau of Drug and Alcohol Services. So the programs that we're talking about are partial hospitalization, outpatient, intensive outpatient, and the individuals within those services are licensed or certified, but it's the program itself. So it's like going to a doctor's office and your physician is licensed, but maybe the entire practice isn't. And if the individual staff members are not doing something that rises to the level of that could be investigated or a complaint, but then there's nothing you can do in terms of oversight. If it's a broad spectrum problem over the entire organization, right now in outpatient, we can't do anything.
Representative Shapiro?
So, first question is, so we're talking about three of these categories.
3, but 2 of them, medication-assisted treatment and ambulatory, can happen at any level of care. So,
They can happen in those
but we're not
programs.
talking about those specifically right now.
Okay, so first question is, might there be people who work in these programs who are not licensed?
Yes.
And what kind of level? Is it office staff, or is it doing some kind of clinical or support work?
Not
but-
clinical work, but maybe support work.
Okay.
People working toward their CRSW but haven't gotten it yet. A lot of times people who are working toward who don't actually start working toward their CRSWs till they've been working there for a while, or don't want to work toward their CRSW because of the time and expense of it.
CRSW.
Certified recovery support worker.
Thank you. So there are some unlicensed people in these programs. And
But like I said, if nothing that an individual is doing arises to a level that you can bring to a board, if it's just a broad organizational incompetence.
Right, so
There's
could
nothing
you,
that can be
could
done.
you make up an example? Or like what would be kind of a broader type of dysfunction or a broader type of misconduct or a broader type of inefficiency of services that might not come under the umbrella of the licensing board, but be a more programmatic problem? Can you give an example?
Yeah, sure. So size of a group would be an example that comes to mind, right? So like an appropriate size of a recovery support like group being held by a clinician, though. So that type of service would be in our rulemaking today for those 9 agencies that we are able to have oversight over.
So the amount of people in a group relative to the
Ratio to
facilitators or
clinician,
the
yeah.
clinicians. Okay.
Following best practice in terms of treatment, using evidence-based practices. That's nothing that the OPLC is going to investigate. But if it's the culture within an agency, then that would be something that this bill would assist with.
So, okay. So, as a former clinician myself, I always concerned when people use the term evidence-based practices because people just use it, but they never talk about what the evidence is. But if there was a practice using a model being used that's a discredited model, that would be an example.
Right.
I mean, there have been groups through the history of substance use disorders programs that are maybe cultish, that kind of thing. So if it was a discredited model or a model that there were concerns about it being harmful, that would come under this versus
Right.
maybe the licensing board. Maybe both, but
Representative Weber?
Yeah, that was kind of my follow-on, I would assume that under most conditions, it probably wouldn't be an either or. But am I right in thinking that one of the issues might be that you could bring an action against a particular clinician for that clinician's actions, but even and remembering that those are quite cumbersome, then you've dealt with that clinician, but there are many other clinicians who might come and continue the program that is still similarly discredited. And may I just put you entirely on the spot and say, is the department in favor of this legislation, at least in concept, or taking no position, or if you don't want to take a position, that's fine. I'm just trying to figure out what page we're all on.
Conceptually in favor, would not be able to implement it without staff. So
Gotcha.
there is language in the existing bill that says with appropriate
Subject
funding.
to funding, yes. And I appreciate that distinction. We hear about that all the time.
And to run an outpatient treatment center, to own one, you don't have to be licensed
Right.
or certified. And so if an owner is saying you must follow X, Y, and Z when doing treatment, well, you can get rid of individual practitioners, but if that's still continuing,
Right.
there's nothing that can be done.
It's also the intimidation of an individual in a very vulnerable state, and how do we bring forward potential allegations of misconduct? And so the idea of making sure that the programs fall under the existing department-wide ombudsman's office could potentially be a critical place for people to report if those things were well posted and education were available to make sure that people knew how to come forward.
Right.
Today, it's a pretty intimidating process to try to name a clinician.
Well, may I have a follow-up?
Yes.
And I now have small amount of greater knowledge because in the course of another volunteer job that I have, I've now encountered the partial hospitalization program, and am aware now that I wasn't before of how very intensive that kind of a program is. So, to me, there's a great difference between something that somebody's going to a couple of hours one afternoon a week, and my understanding is that these are often full-day programs 5 days a week, and very intensive in terms of therapy. So those two things make a huge difference in my mind. And I think, I'll just speak for myself conceptually. I think it's very important, frankly, to have some kind of oversight to the program as well as the certification. I mean, and I come from a background as an attorney. You can't own a law practice unless you are an attorney. So, you know, the owners are subject to attorney discipline from moment one, or at least that's the way it was when I was practicing. It may have changed, but the concern I have is the global organization that comes and you know, they're the employer, they get to say what they're going to do, and people have the choice, well, I'm going to quit and go somewhere else. But I also know the number of people who are motivated to enter this area of care want to help people. And so they're probably not going to be quite so much, okay, my way or the highway, as they would be if they were working in retail and could go to another store. So I certainly conceptually am very much on the side of the department ought to have some oversight over the program, as well as the OPLC having the oversight over individual clinicians, because I think that they're two different possibilities. You can have one bad apple, and that's obviously can be taken care of by OPLC, but it's the overall culture and the vulnerability of the people in the program, by definition, that to me really means that we need to know what's going on.
There are also a lot of out-of-state companies that have started programs in the state that we don't know about because they don't get insurance through Medicaid, they don't get any oversight, and their owners may be from Florida, California, and we don't know who they are, can't get in touch with them, don't know what they're doing.
So, and I'm kind of leaning, you know, as you are towards some oversight on the programs. And I've had some discussions about that. But on the other hand, I do want to push back because there are other folks that push back on me. And, you know, when we talk about, for example, the use of, we don't want to have people using discredited practices, and we agree. But sometimes that can be, you know, maybe a catch-all, which may stifle innovation. And so some of the pushback, you know, that I'm getting because I'm trying to talk to gauge support from a diverse crowd, they're saying is, you know, when you talk about discredited practices, are we going to be potentially stifling some innovation here, whatever. So the ombudsman portion of the bill is there. So if you get into a situation where you have, you know, a clinician is taking on too many people, or they're really engaged in some practices that are really, really out there, is that adequate? Or do you feel that there are deficiencies within that, you know, even with the ombudsman, we still would like to have the program oversight? So I just would like to.
These programs would not fall under the ombudsman unless this certification was in existence. So the ombudsman covers department programs. But today, the way that the way the RSA reads is that the department can certify those substance use providers with whom they're in contract with, which is 9 providers in the state today that we're in contract with for outpatient services. But we know there to be 65 providers registered with Medicaid with over 100 locations. And that's only those that take Medicaid. So the landscape of services that exists outside of whom we already oversee, it would be those 9 providers that the ombudsman could take complaints and investigate.
Right now, without the certification, if someone who was going to a facility that we had no oversight of went to the ombudsman, they wouldn't be able to do anything.
So let me just ask a follow-up question out of complete ignorance. So recently, we brought into place a right-to-know ombudsman, and would it be possible, or is it possible to maybe modify I guess the terms of the ombudsman? So redefine what the ombudsman is able to do and not able to do. So as it is currently laid out, the ombudsman can only do what you say. It can only go through that which is certified, licensed by the department. Is a better approach to basically broaden that portfolio? Or do you think even if it could be broadened to look after this, we would still need to have the oversight of the department?
I think that they wouldn't, what would they be investigating without the rules under certification? So if the ombudsman goes out to follow up after a complaint, but there is no certification of those programs, it's OPLC, or if it's a clinician within the program, that's one thing because you can go to OPLC, but it's sort of that or nothing if they're not licensed or certified. So I think the ombudsman would need to be investigating a breach of something in rule.
I would agree, and I would also add that the ombudsman, it relies on complaints, and this is an extremely vulnerable population who is in, Jamie Powers. I'm the CEO for Life Services for Recovery, which includes Gatehouse Treatment, which is one of the outpatient programs that would be fall under this legislation. And the folks that we're dealing with they're scared. They don't necessarily know what is okay and what is not okay. So the likelihood of them raising a complaint is fairly low, whereas a more proactive certification gives people an idea of who's out there, what's right, and allows the department to have a set of standards that are not currently in place.
So just to clarify that from my own mind and kind of say back what I think you're saying, the ombudsman could go in, if we expanded the role without these rules, he could say, you are a bad practitioner, I can take action on you, but if you're seeing 25 patients or whatever, best practices I can't really get after for the facility.
The current today ombudsman oversees the department's programs. So that means only the 9 that are contracted with the Bureau of Drug and Alcohol Services in terms of substance use treatment. And that means that what the ombudsman would investigate is a breach of the rule under our RSA 172. And so that's where that investigation would sort of take place. If it were a clinical piece, it would still go to OPLC.
Okay, thank you. That's very helpful. You had a question, Representative Weber.
Well, I'm kind of exploring the questions that you had a little further because you were talking about the right to know ombudsman, but I'm wondering if a more apt parallel would be to be the Office of the Child Advocate. And they are given much broader investigatory powers than your ombudsman that we're referring to here have, where it's a very specific and very narrow purview. And so there are 2 things that I'm thinking about. First of all, do we simply expand the powers of the ombudsman to inquire into the treatment of vulnerable people receiving treatment on the one hand, and do we do the whole rulemaking process on the other? I mean, my understanding is that, when the Office of the Child Advocate went to Tennessee and saw the conditions under which kids who were theoretically being treated were basically incarcerated and also subject to various forms of complete humiliation, it seemed to me there may have been actual rules that were broken there, but it seems to me that it was a broader inquiry into the welfare of a vulnerable population. So I guess my question, both for you and for the committee, is would a good first step, if I'd prefer to have all of this, but if we can't, and one of the things I'm thinking about is what we have heard about budget constraints going forward, would it be possible to simply broaden the mandate or the permissible, it's more permissive than mandate, of the existing ombudsman to investigate programs that don't fall under their mandate now?
I just go back to what would they be held, what standard would they be held to without the rulemaking of the certification? So you
gotcha.
wouldn't be able to say, sort of, your group is too large. Back to
Right.
the other example, the ratio of clinician to folks in treatment is too large because that isn't written anywhere, or it's written in rule for those who are contracted with us. But if you're not contracted with us, even if the ombudsman is expanded, I don't know what standard you're holding.
They don't have any
If I'm
requirement.
a private business owner and that person would come to my business and say, I want to investigate you, I'd say under what, whose authority?
Right, okay, fair enough. Thank you for that.
Representative Shapiro.
I apologize, but I didn't catch your name, but I did catch that you're a CEO of some kind of program that falls under this.
Yes,
potential-
Jamie Powers, I'm the CEO for Gatehouse Treatment in Nashua.
And Gatehouse Treatment has which of these types of programs?
Partial hospitalization and intensive outpatient with MAT.
Okay, so can I ask you the question referencing comments that Representative McLean made before about stifling innovation or being, I don't know, maybe another way to put it is being overly prescriptive about what kinds of models of treatment are used and what kind aren't used. So would you have concerns about that if this kind of bill went into effect?
I would not, and the reason for that is I've been in the field in New Hampshire for close to 20 years now, and the model we've always used is evidence-based practices, and that because the definition of that is somewhat broad, and it includes sort of promising practices, that we've seen a great deal of innovation over the years, and sometimes that innovation has become part of our system, and sometimes we've realized maybe it was not our best plan ever, and we've backed away from it. But there's never been a case that I am aware of where by being contracted or a Medicaid provider, I felt that we were unable to innovate in our care.
Thank you.
And innovation in this field is so needed, and we're always looking for new things, that are productive and that really help clients. We're really trying to move in that direction.
Yeah, so I just kind of want to hammer that point home. So you're contracted with Medicaid and you're finding no stifling of innovation, and these rules that we would be bringing forth if this legislation was to pass would be going in that same direction. So basically it's going to be in the same lane. I'm not going to be adding in extra things over what would be for the folks that are
It would be very similar.
very similar. Okay. Thank you.
Yes, I'm sorry.
Representative Weber.
And I'm just going to reiterate one of the points that I think I made at the earlier meeting, which was that not only is innovation important, but I think it seems to me without any kind of formal training in this, it's kind of axiomatic to me that the kinds of treatments that might be effective for me might not at all be effective for somebody else, even though we have an addiction that may look very similar. Our life experiences, our body chemistry, the amount of trauma that we have undergone for one reason or another, and the types may dictate very, very different treatments. And so I want to be sure that we're not either stifling innovation or limiting to any one school of thought, because it seems to me that we need, the more we provide a wide range of things that are useful to at least a certain segment of our population, we're better off. We're serving people
One
better.
issue the field has had has actually been having the same type of treatment for every single client within a program, which is completely antithetical to the direction the field is moving in. It's moving toward very individualized treatment. But that's not really something you could complain to OPLC about. If you're
Right.
using an evidence-based practice, it's just not appropriate for this particular client. Well, it's my clinical opinion that it is. Well, it's my clinical opinion that it isn't. And there'd be no way to really parse that out. So we're really trying to have ways to have oversight of things that are still allowing for that individualization of care.
Okay.
Hi, Michelle Merritt. I'm the president and CEO at New Futures. So we're working on this bill. My colleague Jake has been the primary policy lead, but he is at a national conference this week, so I'm pinch hitting. The only point that I wanted to make as part of this conversation, because it did come up a little bit, is that there is a difference between the licensure and certification of programs and individual counselors, and also what insurance is going to cover. So programs may innovate and they may have, really advanced practices, but there's no guarantee in any case that insurance or Medicaid are even going to cover it in the first place. That may be something that is entirely self-pay, but it would not be stifled by virtue of what we are trying to do in this piece of legislation. They are two separate issues entirely, what insurance is covering and what they're not covering. So for example, best practice would not necessarily be everyone in a 28-day treatment program. However, we know that that's how insurance works. We also know that they do prior authorizations and utilization review on a schedule that does not match what the clinical indication is of a substance use disorder, and put that onus on the providers to continuously redo them. So we're talking about two sort of different things, and I just want to make sure that we're acknowledging that if there are things that are stifling innovation, it is not by virtue of licensure and certification that's happening by DHHS. It's by what is being covered by insurance.
Thank you for that. That's good information. So I think with that, we're going to lose Representative Weber soon, but I think, so we talked a lot about OPLC versus HHS. We talked about, do we go to the ombudsman or not? And I think we cleared up a lot of that. We can maybe let it stew in our minds a little bit and come back to it when we meet again. But I would like to then, let's say we're going to go forward with this path, where the HHS is going to certify. We really went in with some of the amended language, which I think came from New Futures. I think I handed out the amendment where we basically had cut everything down. We got rid of the shall include but not limited to. So I just want to, if everybody's okay, just kind of look at these and, make sure that within the scope of what we talked about earlier, this is what we want to cover. Do we take stuff out? Do we put stuff in? Is it too comprehensive or not comprehensive enough? So I'd like to kind of open that up. And did you want to say something?
Yeah, I'll just add that at the time in which New Futures was supporting committee members around an amendment for this particular piece of legislation, even what you see before you was not the ideal that we had wanted to put forward. It was really to try to get a compromise that we could get something done this session, because there was urgency in regulating these programs, and we were hearing in real time about individuals who were being harmed by programs that the DHHS had no ability to regulate. My suggestion would be that the advocates and others get together with DHHS and we take another look at the entirety of the bill and potentially even overhaul it, so that we are directly addressing the set of issues that we've described here.
And could I?
Representative Weber?
And I'm just gonna, I'm comfortable with what I have in front of me, which has several layers of revisions. I think that starting with something that both people running the programs and the department think is workable is a very good idea. But I'm going to remind people that, at least on the House side, the windows of opportunity are very narrow and coming at us very quickly. And, we will only have that window of opportunity in November. The Senate side, there's a little more wiggle room, but, I just want to make sure we all have that in our minds as we're.
Yeah, we've been working in partnership with the
Discussion.
Department of Health and Human Services through the entirety of this. So I have no, hesitation at all or concerns that we would not be able to come up with something that is mutually agreed upon.
So, Mr. Chairman, could I make a suggestion, which is,
Yeah.
My suggestion, just because of the most immediate thing, I believe that our chair is thinking about a meeting of our full committee the week that is the veto day week, which is coming at us very quickly. My suggestion was perhaps that we make a motion that this be recommended for further legislation. And then we can certainly go on working on it from now till whenever, and maybe try and nail down some of the specifics. But if we at a minimum as a subcommittee recommend it for further legislation, that takes care of that one deadline. We can talk to the committee about the lines along which we are thinking. And I think, to me, it sounds like what we have here is sort of a floor, and then maybe there are other things that people would like to see in there as well. And I don't know whether that's one bill or two bills, but it seems to me it gives us a lot to talk about going forward. And whether it's filed as one bill or two bills is for more discussion.
I was unaware that he was looking to do that on the 10th. So I hear what you're saying.
It's actually the 8th or the 9th.
The 8th or the 9th?
Yeah.
So, however,
Because the 10th is veto day.
however, I would like to, because my intention here is to have somebody, hopefully, who is going to get reelected from the subcommittee, put in the language. And I would like to have as much information to be able to vet that language when we come back on the 8th or the 9th. And if I develop that language after that time, we may have something that we're comfortable with, but we're not going to have the opportunity to test it until the new year. And because we have very different opinions. Those of you who were around for the original hearings in the spring. And so I really want to come back with as much of a direction as possible to understand those folks that had concerns, how far have we gone to addressing those concerns? So when you say you folks are close, I mean, how close are we? If I was to, I'm going away next week on holiday, but I'll be back the following week. Would that give you enough time to be able to say, hey, I have something that we could bring back? Do you think?
Well, I'm just going to point out that the committee will not vote on the full language. The committee only votes on recommend for further legislation or not. So it doesn't matter as much, as far as I'm concerned, that we actually have the language sitting in front of us, because that's not what we vote on as a committee at this point. But I understand that wanting the concept and also wanting to address certain of the issues that we know are going to come up, particularly the issue of, is this going to stifle innovation? Is this going to prevent people from trying new things or to emphasize a particular kind of program with a particular sort of client? Those are things that I feel more comfortable about, having discussed them, even if I don't have the specifics in front of me. I think it's just a matter of the time frame and what we get when. But it's not going to be the job of the committee on whatever day the committee meets as a full committee to wordsmith a full amendment or a new bill.
I agree with that. I was just hoping to have as much of a vision
Absolutely.
as possible, for the committee. Well, I'll just do a quick straw poll of the committee members. Do you think it's worth it to come back again before that? Because I do believe I'm comfortable. I have enough information to recommend for future legislation. I think we talked through the questions about the innovation, the fact that, we're migrating in the areas that are covered by Medicaid makes me feel very confident, and this legislation is going to be closely mirroring that. So a lot of those things are there. So I'm comfortable. but I'll just do a quick straw poll of you folks. Do you think there's value in coming back one more time before we go back to the whole committee? Or what are your thoughts?
Well,
I'm not going to give you my thoughts on that yet.
Okay.
you don't need a mic, Joe.
First thing is that in this amended by the Senate bill that we have, I didn't read it through before, so I'm missing it.
And
But
I'm sorry, Joe, I'm going to interrupt because I do actually have to be on a meeting at 2. I think it would be very productive to come back, but I'm out of time because I'm going to be gone for 2 weeks, starting in, I'm gone from the 20th to the 5th. Just so you know. But that doesn't mean you can't meet without me. I'm certainly, my vote is in favor of that we recommend to the full committee, recommend for future legislation. But with that, I'm going to have to run, and I beg your pardon for the interruption.
That's your vote. Okay, thank you very much. Good luck.
so I'm just going to say that I'm not sure, you mentioned it in terms of actually being able to implement this, there would be certain costs to the department, and I'm not sure that those are represented in here in any way. So I think that's something that eventually, when a new bill is brought forward, should be clearly represented.
We did submit a detailed fiscal note on this bill last session.
Okay, so-
And so we have those costs at our fingertips if you'd like us to send them to the committee. The amendment included subject to available funding, which then made it somewhat fiscal neutral. But it's not, it's just whether or not we have the funding.
Okay, I'm not running, so I'm not going to be here, but I just think that that's one of the missing pieces. I'm in favor of voting I'm in favor of recommending that this bill comes forward in the next session. And I don't personally feel the need to come again to kind of work on the details of it. I think in the original session, it was so cloudy somehow that people were asking, well, does this mean we're going to regulate Alcoholics Anonymous, for instance? And I think that more than changing anything, I think as well as changing some things, we've become clear on what this bill would do and what it wouldn't do. So I feel comfortable in recommending it for being reintroduced and having people who were very involved in it continue to work on that.
So, I think we lost Representative Weber. So I think, do we, with the subcommittee of 5, if we want to take a vote to recommend for interim study, to take that to the whole committee, do we need to make that decision here, or can we have that discussion when we go into the committee as a whole in October?
I think we make it in the committee, not here.
Okay.
I think. I mean, we can do something informal here, but I think it.
So Representative King, what are your thoughts?
So to answer your last question before I go on to my thoughts, I'm not an expert on how committees run, but I think there was 4 of us here that are in favor of moving forward with this, with Representative Weber making her thoughts known before she left. So I think we have, and besides that, 3 out of 5, I think, makes a quorum anyway.
So are you then of the same opinion that you know what you need to know?
From what I've heard, this is a little different than what I've understood before, and it makes sense. I'm with Representative Shapiro that we really need to be clear on what we're regulating. I think that was the big problem we had back in the spring when we heard this bill was, are we going to have people just taking over and trying to control things? And from what I heard today, that's not the case. So I'm in favor of moving forward. The other clarification that I need is the language that is being written. Is this coming from DHHS?
it's my understanding it's being, DHHS been working in conjunction with New Futures on it, so.
Okay.
So, just before we move on, we have the chairman of the committee as a whole in, so when were you planning to get everybody together to take up these interim study bills, Mr. Chair?
I conferred with Representative Weber, the ranking member of our committee. We're tentatively looking at October 9th right now. I'm meeting with staff this afternoon to see, we have 13 interim study bills, and seeing if there's any interest in any other subcommittees. There's only been two real subcommittees. One met this morning, and this one. And so right now we're looking at least one meeting occurring on October 9th. I know there's another meeting that afternoon. If we don't get through everything, then we'll have a subsequent meeting. Everything has to be wrapped up before October 25th on interim study reports.
So thanks for that. So I think with that being said, if it's okay with the rest of the committee, we'll go forward when the committee as a whole meets. We'll come in, we'll recommend. But with that in mind, would it be possible to get that newly amended language within that timeline? Because I would like to have an opportunity to review it, to send it out to the other members of the subcommittee. So at least, even if we're not getting back together, they've had a chance to look at it. So how's that timeline work for you?
Yeah, New Futures has a really good working relationship with DHHS, so I'm sure within that time frame we can get together and come up with some amendment language and get that back to you.
So with that being said, does anybody have anything else they want to add, Representative King?
Yeah, for the minutes, I wanted to put what date that was going to be. Is that October 8th?
The full committee meeting or the deadline for interim study? And again, what I'm probably going to do is send an email to the committee. We do need to make sure we're going to have a quorum on that date, but October 9th is the date I'm looking at.
Okay.
Probably a 9:30 start date, and I know there's a Democratic caucus at 3 that day, so we'd try to wrap up by 2:30, if not before, so people can ideally grab some lunch. And if we're making slow progress, we'll probably have to adjourn and continue everything to another day, but my thought the notice would probably read a full committee work session and subsequent executive session on all bills. That would be the goal. And again, as Representative Weber has pointed out earlier today, and I don't know if she did at this meeting, the only thing the full committee is going to be able to do is either recommend for future legislation or not recommend. None of this is going to go to the floor at this point. It's going to have to come forward as a new bill in the next term. So yeah, October 9th, and then the ultimate deadline for all interim study is October 25th.
Thank you. So is that everything that you need then? You're all set?
Here's the tricky one. Who moved it and who would like to second it?
There was some discussion when you were out of the room about whether we take a formal vote here, or do we just bring it to discuss it informally and have an informal vote and then bring it to the full committee?
Yeah, so we're not going to take a vote today. We're going to just bring it forth to the committee, discuss it.
I mean, do we need someone who makes a motion and a second?
Well, I think for the committee to consider what happened here, it would be nice to have a formal sense of what the committee wants to do. Whether you want to do it as a vote or want to just gauge if there's any formal objection or whatever, it would be good to know a formal sense of what the subcommittee wanted to do, or what wants to recommend.
That's right. So then I'll make a recommendation for submit for future legislation.
I'll second it. And I think Representative Weber retroactively voted for it.
But she's not here, so let's keep it legal. So all in favor, say aye.
Aye.
Opposed? Good. So with that being said, I just want to thank everybody for coming out, members of the committee and you folks. Like I said, a lot of questions, a lot of pushback, but I think it's important because there's a lot of pushback from the folks of the committee as a whole. And so some of the questions we've been answering, I think will go a long way towards addressing some of those concerns. So I really appreciate everybody taking the time out to come in and talk with us. And with that, this hearing is adjourned. Thank you.
Thank you.
My friend.